IMSR auditorium, the Parallel University. And it is a unique one, possibly will continue up to 6 o'clock today. In this context, I'd like to thank Dr. Purab Desai, who is a Conclave Chairman, Dr. Alpesh Shah, Organizing Chairman, and Dr. Gaurav Sharma, Organizing Secretary. My point of discussion today is very simple, but it is very difficult to utter because we are talking about the establishment of a hospital, in fact. I have given the talk about the opportunities and the challenges in homeopathic IPD. I had a little bit of changes in the topic that opportunities to nurture and challenges to conquer in homeopathic IPD. If you see my first PowerPoint, I'll request to go with the next PowerPoint. Next slide, please. Here you find the deeper case understanding. Means when a patient gets admitted in the hospital, we all, this faculty, the doctor, the nurses, the support staff, they all get a longer observation period. I will come to discussion how it differs from the modern medicine hospital and our system of medicine, the homeopathy system of medicine. We get a longer observation that allows the collection of fine and characteristic symptoms. You will believe it that when you go in the OPD, when a patient comes to you, you remain in a hurry. Moreover, there is a time constraint. Moreover, there is a problem with the issue that the support staff will go away, and you do not get much of the time for the case taking. It is true, and you have to believe, one has to believe, that homeopathic case taking, to understand the fine symptom, the characteristic symptom, the indicative symptom, may not be possible in the outdoor, particularly in the chronic cases. So when we set up our IPD, and it gives an establishment that the deeper case taking understanding, that to our target remains, the longer stay target remains to collect the fine symptom, the characteristic symptom, and the better remedy selection what we can do. This part we all know, we all understand this. The longer the stay in the hospital, we will get more of the symptom and we can go ahead. And this IPD, another opportunity for the IPD admitted patient is that the faculty, the PGTs, they get enough of teaching opportunities. The teacher gets opportunities to learn from the patient. The teachers, when they are stuck somewhere, they get a referral, they get some expertise opinion, and they also do learn. And the IPD is a place from where we can initiate the research methodology, the research work, the case documentation. Those helps in the research procedure to start. And the important one is that when a patient gets admitted in the hospital, soon the patient gets admission in the hospital, we start with the patient starts with the trust building through continuous care. The support staff coming, they are measuring the blood pressure. The nurses coming, they are asking their health status. The postgraduate trainee coming, they are asking for the symptomology, fine symptomology. The faculty coming, they are also giving some importance to the patient, and there is a trust building between the patient and the faculty and the doctor, treating doctor. That is again a opportunity in case of admitted patient. Indoor patient care enhances the patient confidence, in fact, and especially in the chronic cases, we do admit the patient who are chronically ill. We do get many of the lifestyle diseases. We all get many of the autoimmune diseases that in fact needs a fine to finer symptom, the characteristic symptom, the long duration stay, as well as the good care by the support staff. that makes us trust, as well as we get the final symptom to evaluate, to select a remedy once a patient gets admitted in the hospital. And we get enough opportunities that that helps us evaluating remedy in relation to reaction. Suppose we give certain medicine that does not work, we go for the complementary remedy, which may not be possible in the OPD setup that we get in case of OPD admitted patient. If there is some kind of acute exacerbation of the symptoms or the disease process while treating, you get an opportunity to tackle that situation by giving the second prescription. We can more adhere, we can more align with the Hahnemann way, the way the Master Hahnemann has said to treat a patient. Unless a patient gets admitted in the hospital, this opportunity may not be possible only by the treatment procedure what we have dropped in the OPD system. And demonstrating holistic healing. Can I go to the next slide, please? Demonstrating holistic healing, controlled IPD environment. This controlled IPD environment allows full implementation of your diet section, the regimen, the emotional support they do get in the hospital admitted patient. It is in fact, whenever we talk about the diet regimen and emotional support, it is in fact we are talking about the Hahnemannian way of treatment. That is possible in the hospital setup. That is possible when a patient gets admitted in the IPD for their treatment. Next point to discuss is that whenever you are admitted a patient in the hospital, you get much of the scope to interact with your peers, to interact with your fellow, interact with the other faculty too. Faculty who is master in Veterinary Medica can talk with the master of the organ of medicine. And that interdisciplinary, I'm not talking about the modern medicine, Ayurveda, etc. Interdisciplinaries here, I would like to restrict with the subject concern of homeopathy. That a Veterinary Medica teacher gets enough opportunity to talk with the organ teacher, to talk with the pharmacy teacher, to talk with the expertise from the pediatric department. And this collaborative way makes a good support in the treatment procedure while a patient is admitted in the hospital. That is the good part of the hospital. There are endless number of good part of admitted patient, good part of the establishing IPD in each and every hospital across the country. There are many opportunities. I'll come again. We'll come to discussion into it. But for the time being, let me talk about the challenges in homeopathy, and these challenges we need to conquer. That we have to talk about. There are many difficulties. Many of us do not understand till date, that what is the use of the IPD in a homeopathy hospital. By saying so, we are not much encouraged to establish an indoor patient department in each and every hospital. But it is true, unless we have indoor patient department, you do not get much confidence in the patient who are being treated at the OPD level. If a patient understands that you do have an IPD, they will feel that, they will have a confidence that whenever they have an acute exacerbation of their suffering, they will get an opportunity to get admitted and the doctor will take the necessary step. That confidence we have to give at the outdoor level. Unless we have an IPD, we cannot give this confidence to the patient. As you compared with the modern medicine, you will find the patient understands. If I get more of the symptom, if my symptom gets more aggravated, if I get more ill, if my health does not permit me to stay back at my residence, I can take help of the doctor who will admit me in the hospital. That confidence they do get. But in our system, homeopathy, across the country, this is lacking. That is the reason that we have to build up our mind that we have to encounter each possible challenges while establishing our IPD in each and every homeopathic hospital across the country. What is the first challenges is the budget. Is the budget is the money. Unless you have money, you cannot establish a good setup of hospital. That is the priority. So once you do not, if you have enough money, then only one can go with setting up of a good indoor patient department. Unless you have a money, it is a very useless to talk that we need hospital, we need IPD, we need OPD, we need infrastructure. But the target will be towards the collection of the money. If you are in government sector, you can approach government. If you are not in government sector, you can go with collecting money from the NGOs. You can generate a fund. You can make a procedure how to collect the fund. You can approach the government in under National Ayush Mission. You can ask. You can go with different research procedure. That there are many research. Facilities in the Ayush ministry that if you give a good proposal for certain research, you will get a fund. And by that fund, you can develop, you can improve your infrastructure within the indoor patient department. So the budget constraint is the main one. This is the authority, higher authority of a hospital. They have to understand how the money will come. That is the first and foremost responsibility to establish our indoor patient department, and you can continue with the good infrastructure of the IPD. Another point of discussion is that among the challenges in IPD is that lack of emergency facilities. You will find many of the hospitals, they do have IPD. They do have the IPD, but one has to remember, once a patient gets admitted, it's not one patient, there can be 100 patients admitted. Out of this 100 patients got admitted, one or two can have acute exacerbation of their suffering, sudden emergency, sudden acute exacerbation of the respiratory distress, sudden cardiac arrest, sudden ischemic attack, that can develop. What can happen at home? That can happen also in the IPD. But the trust level is that when a patient is admitted in the hospital, your responsibility becomes much more. So one has to, one IPD hospital, one IPD has to have all possible facilities, at least to tackle one or two patients at a time, not like the modern medicine, all patients, one or two patients at a time to tackle with emergency facilities. That one has to understand. We need to establish our IPD in a sense that the calling for the readiness without ICU like setup, that one has to establish each and every IPD has to get established with that readiness of ICU like setup. It can be one, it can be two, but unless we have this, the patient will not get confidence to get admitted in our hospital. What I'm talking about is my talk is in the line of establishment of our own hospital, that National Institute of Homoeopathy, that we have a 100-bedded hospital, and what we exactly do, that is being reflected out here. That we do have a certain cardiac monitor, we do have certain defibrillator, we do have certain resuscitation system, so that whenever a patient gets sick, that patient gets immediate rescue operation out there at the bedside. That one has to remember. Then in challenges, another point is that this is by virtue of, in the line of talking of the budget constraint, another point is that the manpower limitation. Manpower, without the support staff, without the security, without the MTS, without the GTA, without the IR, ward boy, without the nursing staff, without the RMO, without the residential doctor, you cannot run an indoor patient department. Because this world is now aligned with the medical legal, that whenever you admit a patient, all setup of the infrastructure, all setup of the manpower is mandatory, that one has to recruit that one, and you have to keep the manpower in position whenever it is needed or in the daily routine wise. The difficulty in retaining skilled nursing staff, that skilled nursing staff needs money again, that you have to pay a good amount of money to them, and skilled support staff, you need to pay a good amount to them. That once you get a good skilled nurses, once you get good skilled support staff, you can go with a good indoor patient department. But again, that if you have a money constraint, if you have a fund constraint, if you have a budget constraint, then one may not have the power to establish a good quality of the indoor patient department. And the next point to discuss is that, can I go to the next slide, please? Next slide, please. Next. Next slide, please. नहीं, उसका आगे वाला. उसका previous one. Yes. That is what a few minutes back what I was discussing is that the public perception issues. Public perception is many people still associate indoor treatment, that they understand that indoor means injection, indoor means drips, IV fluid, indoor means surgeries. Once you ask the patient to get admitted in the hospital, in the OPD, when you ask the patient to get admitted in the hospital, they understand that what is the use of getting admitted in the hospital. They will say that I don't need to get on admission because I don't need a surgery, I don't need IV fluid, I don't need an injection, etc. But you have to, in the OPD level, one has to make them understand that the system, what we adopt, the homeopathic system of medicine, that do not go with the injection, do not go with the IV fluid unless it is emergency. Unless it is emergency, we do not also go with the surgery. So this is not the need of getting admission. One has to say to the patient, for your better understanding of your disease, we are admitting you to the hospital. So many of the patients will refuse the admission because they don't like the admission at the hospital. But the treating doctor at the OPD, that becomes his primary responsibility to make them understand that the hospital is for the keen observation, more good observation. You can stay back in the hospital with a good comfort, and we will try to understand your symptomology. We will make the disease diagnosis, we will make the selection of the drug, and we will make a future plan of the treatment. That part of word has to be told to the patient when you are treating the patient, when you are referring the patient for the admission in the indoor patient department. And in IPD we do have another issue is that once the patient gets admitted in the hospital, there is a problem in the documentation. You do have an admission procedure. After the procedure, that patient goes to the nursing staff. They give the bed to them. Then they write, the doctors comes. The doctors write the medicine in the file. That in the file that goes in the nursing exercise book. They record it, and then after 8 hours, when they go away, the new staff comes. There is a process of handover. There are many of the documentation. And the end of the treatment, when the patient goes back, there is a procedure. And the patient, when they go back, you keep that record as a medical record, and you have to register all this medical record. You have to keep this medical record for certain periods. And that is this documentation, enough of the documentation that one has to go with. And for this documentation, again, you need a skilled nursing staff that who can make this documentation well. There I find in our hospital 6 to 7 documentation exercise book that those are kept in the table. We do have the diet documentation. We do have a medicine documentation. We do have a dressing documentation. We do have a follow-up documentation and the full of documentation. The sister, the nurses, they keeps on writing and writing all the period, and that becomes a mandatory, that becomes a necessary documentation. In this context, what I like to say is that the physical documentation is possibly in IPD is always better, because whenever you try to put this data in the computer, when the next person comes, he has to open the computer, he has to the booting time of the computer, and where it is lying, this becomes an absolutely difficult one. You can document all this in the computer later on or the simultaneously, but the on paper documentation is absolutely necessary, because that is kept over the table. The doctor comes and opens it and find it. The sister comes and opens it. The postgraduate trainee comes and opens it. Whenever it is easily available, that becomes a good one. The documentation is a procedure where we document all the data and the incident, what has happened in the hospital, everything been documented. Unless we do have a documentation procedure in IPD, you cannot run a good IPD system of medicine. That is another challenge that one has to go with. That documentation, one has to train all of the support staff, all of the nursing staff, and they will keep on doing that documentation, and we can be happy with this paper what are kept in the table of the nursing station. Next, we'll talk about the integration with the investigation support. That in IPD, we can do a certain routine investigation. That whenever a patient is admitted, that the patient needs a blood test, the patient needs a X-ray, the patient needs a CT scan, the patient needs the ECG, etc., echocardiography, etc. And that can be placed in the outdoor. That patient will go there and they will get investigated and again will come back to the hospital IPD bed. That system has to be evaluated. That minimum investigation in each and every hospital, that has to be there. Unless we do have a pathology department, unless we do have a biochemistry department, unless we do have a radiology imaging department, unless we have a sonography, unless we have a ECG, we cannot claim that we do have a good inpatient department, because almost all patients needs a routine examination, as well as whenever necessary they need to get investigated. That has to be ensured in each and every hospital where there is a IPD facility. We will also focus on the patient compliance inside the ward. Next, patient compliance inside the ward, that has to be ensured. Managing chronic patient expectation and their emotional state always has to be just. Here, I would like to say that whenever patient is admitted in homeopathic hospital, many of the patients are not the bedridden one. They are free to walk. The certain patients, those who have a neurological disorder, like they have a hemiplegia, or they have a normal facial hydrocephalus, or they have a degenerative diseases, certain diseases of the brain, or they have a chronic, they have a COPD patient, or they have a certain kind of respiratory distress, or they have a acute abdominal pain. All patients, all time may not need to be kept in the bed. They will just get up from the bed, they will go away. They will roam around the corridor, then will come back. They will be near the window, they will see the nature, and they will again come back. That is the tendency, that is the way of the admitted patient of the homeopathy hospital. It's not like the modern medicine hospital. All patients lying in bed with catheter and Rayleigh tube. It is not the way, it is not the scenario of a homeopathic hospital. So what we need to do is that that patient gets enough of free time, enough of free time. So in this enough of free time, in our hospital setup, we allow them to play. There's someone plays the small games over the bed that we allow. We allow the mobile too. They get engaged in the mobile. And in the corridor, we do have a good quality of television that they enjoy their sports, they enjoy the TV serial, etc. They are engaged into it because emotional support again is a therapy that that some if somebody is engaged with certain works, that is again a therapy to them. And moreover, this longer duration of stay with the daily activity with them, we do get certain more important symptomology, and we write it down, and accordingly one can prescribe the right medicine to the right person in the right time. That is what in the free time of the patient, we will always try that the patient will be engaged with certain responsibilities, certain entertainment, and that one has to ensure in the IPD setup. If I please the next slide, please. This is by my talk. By this time, we have said many of the points that how we differ from the modern medicine. That once you understand that I have to establish the indoor patient department, in your mind it comes that you are establishing an inpatient department like that of your modern medicine. But it is not true. It is not wanted at all that your concept, your idea to establish our inpatient department should be different from the modern medicine hospital. Because modern medicine hospital, they always deal with only with the emergency patient. That in our system, one we have to understand that not only the emergency, but we will keep certain patients who are chronically ill, but they have a tendency for the acute exacerbation of their suffering. Those category of patients will be admitted in our hospital, in a homeopathy setup of hospital. Moreover, certain diagnosis, even in the modern medicine too, that is by diagnostic tools, it is not been diagnosed. It is only diagnosed with keen observation, particularly in neurological cases. We have seen that the many of the patient gets diagnosed after 2 days, 3 days time of their stay in the inpatient department. That is the reason that we differ. It is different from the IPD of modern medicine. In our system, we are separate entity into it. That IPD has to be get established with our own ideology, our own concept of medicine. That one has to remember. Homeopathic IPD is not just active just for the active treatment, but for a deep case understanding. That for deep case understanding, we are establishing our inpatient department. We admit patient to refine symptom collection, not simply for intensive care. The goal is to understand the totality of symptom, evaluate miasmatic background during the stay or in the hospital. We need to evaluate the miasmatic background and the plan of future treatment. That is the goal of our admitted patient. We do not admit patient for intravenous drugs, as you said, intravenous drugs, infusion, procedure like in modern medicine, we do not admit them. Instead, our purpose is observation, follow-up, and holistic evaluation. Physical rest and emotional support, as we said, also contribute to cure. That is, physical rest and emotional environment is basically support for the recovery. It is a kind of therapy, in fact. Chronic diseases are the focus in IPD admission in homeopathy, that we all understand. The condition like certain psoriasis, certain neurodegenerative disorder, autoimmune diseases, as we said, the COPD cases, as we said, the chronic fatigue syndrome cases, as you said, some cases of the chronic pancreatitis patient, as you said, some cases of cholelithiasis patient, and most importantly, the cancer patient who are terminally, the terminal cases of the cancer, those cases been admitted in the homeopathy hospital. So these patients do not need acute intervention, but they need a structured, quiet, and observant environment. That is one has to ensure while we established our indoor patient department. However, we must not ignore the chronic disease can turn into acute. That, as I said, that any chronic disease can turn to acute exacerbation. Even in homeopathy, chronic patient can have acute exacerbation, leading to condition like seizure. It's good that if somebody gets admitted with the S-well brain, somebody gets admitted with the S-well brain, and he was happy with the treatment. One day in the fine morning, the doctor noticed that he has an attack of seizure. And starting from the World War, starting from the nurse, starting from the postgraduate training, starting from the faculty member and the associate doctor in the hospital, they must be very accompanied with how to tackle a seizure disorder by establishing the airway, by giving the appropriate medicine in the right time. So when patient gets admitted for a chronic illness, one has to understand what could be the acute manifestation of this patient and the remedy which can come in acute manifestation. That in well advanced, it has to be noted in the file, and we will remember this that in acute exacerbation, what medicine to be given, that preparedness has to be made well in advance. That one has to ensure in admitted cases of inpatient department. Our goal is not to copy modern medicine ICU. We will not copy modern medicine ICU, but we ensure safety and readiness. That is the reason one ICU-like setup has to get established in each and every inpatient department. We may not need ventilation for every ward, but at least the trained nurse, trained technician, there can be in the hospital who can come on call, not 24 hours, on call who can come and can do a BiPAP. That facility has to be there, at least for the oxygen therapy, that someone in the ward for 24 hours should be there who can administer oxygen therapy. That sometimes we need the IV fluid in case of severe dehydration or in certain suffering too, that one has to be skilled with, that nurses has to be skilled with how to give an intravenous IV fluid channel, how to create IV fluid channel, and following which that IV colloids can be given to a particular patient. That one has to ensure. That is the reason we say that we may not need a ventilator in the ward, but the support staff should know the cardiopulmonary resuscitation procedure. The CPR one has to know, and we can establish by this way that whenever if there is an acute emergency, like cardiac arrest, one can cope with the environment and can get a good procedure of the treatment out there. Emergency referral again is an important one. That what we like to say is that this every patient by homeopathy you cannot treat. Patient can go worsening and worsening. By that time, one has to ensure, one has to establish the protocol, one has to establish a move with the other hospital, maybe with the modern medicine hospital, that this patient will be referred to you, and the appropriate treatment at once the patient can get. That procedure one has to establish. The referral protocols one has to establish. And where we are referring, the referred hospital, the staff, beginning from the staff to the doctor, you should get a good rapport with them. You make a phone call and you say that this patient is going to you and this patient have this these complaints and you take appropriate measures, that will be the fantastic way out, because we need the golden period time that has to be utilized in certain cases. So if you have a good rapport with the referring hospital, that will be a good protocol in fact, but it has to be there. We do have. We do have a good protocol with the state government hospital. We do have good protocol with the certain hospitals surrounding us. We make a call and the patient goes there. Immediately they get medicine, maybe in the modern medicine too. So that has to be ensured. Whenever you cannot, then that patient has to be referred. That has to be referred, and protocol has to get established. Investigation in homeopathy IPD is for understanding the person behind the disease. And as you will know that not only the pathological investigation will help in disease diagnosis, but this pathological investigation, the X-ray, MRI, CT scan, all this helps us, once it is there in the IPD, helps us to establish a good miasmatic background. Again, this has an immense value. The investigation has immense value, not only for the disease diagnosis, but also for to understand the concept of miasm. That has to be considered. IPD stay maybe longer.
Requesting you to kindly conclude in 5 minutes, sir.
Okay. Yeah. Once it's done, please let me know.
Sir, sir, you may continue and conclude in next 5 to 7 minutes, sir.
Okay. Uh, I can continue. Is it audible well or there is a howling?
Yes, it is audible, sir. Kindly conclude in next 5 to 7 minutes, sir.
Okay. Okay. What I've been talking about is that the IPD stay may be longer, but that should be more meaningful. And patient admission is a part of the therapeutic tragedy. What I like to add on into it. Documentation in our system should be the case centric, not the procedure centric, as we said earlier too. Let us not compete with the modern medicine. Let us not compare with the modern medicine hospital. Let us sign in our depth of human understanding. That is the way out of your homeopathic system of medicine. And now to talk about a few minutes with the IPD establishment, I will be very fast into talking about it. That strengthening the IPD services in homeopathic hospital, what we exactly need to do. That one has to remember the OPD is the gateway in IPD. That unless you do have a good, well-equipped OPD in homeopathy hospital, you cannot establish a good IPD in our hospital. While you open an IPD, one has to remember that expandability and the flexibility should be your mission. The expansion of the hospital should be there. You have to cope with the emerging diseases like right now there are many patients with the dengue are coming. You need to open a dengue ward. Whenever a diarrheal disease comes, you need to open a diarrheal disease ward. So expansion should be the criteria, and the flexibility means once you decide the physiotherapy department should be shifted to the medicine department, medicine department should be shifted to the pediatric department, etc. This flexibility one has to always have to cope with the emerging diseases. And to talk about one point is that this in OPD and as well as in the IPD, especially in the OPD, one should have a triage room, because in the triage room, once a patient comes with a chronic illness, that patient might have the acute exacerbation of their symptom. You shift the patient to the triage room, evaluate the patient, and understand that whether this patient can get admitted in our hospital setup or this patient needs to refer to the modern medicine hospital. That triage room will decide that part. If once you are confident that this patient can be admitted in the homeopathy hospital, one has to admit the patient accordingly. One has to remember that our hospital is OPD department dependent, because no patient comes to our homeopathy hospital with the ambulance directly to the IPD. It is always via OPD. And an OPD patient who are being treated for long period, they only get admitted in the indoor patient department. This is one part. Uh, in strengthening the IPD structure, once again, what I like to say is the financial support. Financial management has to be there. That let us admit the budget is a limit to us, but we must still aim to effective fund allocation, timely utilization of the fund, and regular financial audits has to be there. The part what remains most important in IPD is that store and maintenance section. That in store and maintenance section, all equipments, all tools has to be sufficiently available in the store and maintenance department. Maintenance means you need to do a certain annual contact with certain agencies like the lift, like the electricity devices, like your solar devices, etc. AMC, annual maintenance contact has to be there. And in store maintenance department, the calibration is the important one. That with the uncalibrated machine, you cannot continue with the investigation. You can continue with the measurement of the blood pressure, measurement of the oxygen level. You need to make annual maintenance contact with certain agencies, and you need to do a calibration of each and every machine, like your BP machine, like your weighing machine. And those has to be calibrated in time. IPD, where the system is a system where there is human touch. We must understand it is not just a place with pets, but as a highly coordinated care ecosystem that one has to ensure. The nursing staff are the pillars of the IPD that we have talked about it, and the documentation is still the physical documentation in hospital. It always winner that this digital documentation is good, but the physical documentation has to be there. Cleanliness and the patient engagement, as we said in patient engagement earlier too, the cleanliness in our hospital setup at National Institute of Homeopathy, Kolkata, as well as at Narela, we clean the hospital for better hygiene. That every 4 hours that we clean that one, because there is a long stay in the hospital section in homeopathy hospital, and there is always chance of the nosocomial infection that we always try to avoid it. The dietary system has to get established by the diet system. We do have a dietitian, we do have a diet support staff, and they give the timely diet to them, the breakfast, lunch, evening milk and all, and tea and dinner too. That is being supplied. And the most importantly is that in the hospital, the staff has to ensure the capacity building. That doctor has to get capacity building training. The ward boy Aya has to get a capacity building training. The nurses has to get a capacity building training. in certain interval, they has to go with the training, and that upholds their standard, that gives encouragement to them that I have to do it, and the support staff gets a much of encouragement that he understands his needs in crisis. Unless we do a capacity building program, that confidence levels of the staff will not be built in their mind. That is the point. And as administrators, there should be someone who is the administrator. They has to always monitor the quality. They has to always go with the inspection. They have to monitor. They have to do quality monitoring. They will listen to the demand. They will understand the difficult spaces. They will understand and they will analyze the time gap. They will understand that what exactly needed for the patient, and they have to take step into it and to procure the item or to solve that situation that the administration has to go with. A good administrator, who happens to be a good clinician too, can understand well the difficulties and the challenges, the opportunities in the inpatient department. So this was a discussion in short. There are endless points, ceaseless point, numerous points to discuss, but it was a very happy moment for me that I've been with you. You've been listening to me for a pretty long time, and I believe that some point I could discuss, I could focus in from